The development of the heart begins in the middle of the 3rd week of gestation and is completed by the 8th week. This animation will illustrate the development of the heart tube, formation of the endocardial cushions, as well as the partitioning of the atria, ventricles, and outflow tract. We will also discuss the most common congenital heart defects. The heart develops from 2 endocardial heart tubes, which fuse in the midline to become a single heart tube that is able to pump blood by the 4th week. As the endocardial heart tubes fuse, several bulges and sulci appear. Starting from the cephalic end, we can identify here the Truncus arteriosus, bulbus cordis, the primitive ventricle, the primitive atrium, and the sinus venosus. The heart tube continues to grow, and on day 23, it begins to convolute. The cephalic portion of the heart tube bends ventrally, caudally, and towards the right. Meanwhile, the caudal portion of the heart tube bends dorsally, cranially, and towards the left, creating an S shape. This will cause the bulbus cordis to be ventral and to the right, and the primitive ventricle to be ventral and to the left. Meanwhile, the atrium and sinus venosus will become dorsal to the heart loop. As the cardiac looping progresses, the atrium will become more dorsal and cranial. At the same time, the primitive ventricle will form the left ventricle, whereas the right ventricle will originate from the proximal part of the bulbus cordis, and the distal portion of the bulbus cordis will become the outflow tract of both ventricles. The pulmonary artery and the aorta will originate from the Truncus arteriosus. Now, the septation of the heart will be reviewed. The ventral view of the heart is illustrated on the left, and the lateral view is illustrated on the right. By viewing the heart from the side, partitioning of the atria and ventricles can be easily visualized. Development of the endocardial cushions will now be reviewed. At the end of the 4th week, dorsal and ventral endocardial cushions originate from the walls of the common atrioventricular canal. They extend and grow towards each other from opposite sides. By week 6, they fuse, dividing the common AV canal into left and right atrioventricular canals. Atrial septation begins at the end of the 4th week. The septum primum grows from the dorsal wall of the atrium and extends toward the endocardial cushion, progressively constricting the opening between the atrial chambers, forming the foramen primum. As the endocardial cushion and the septum primum grow towards each other to close the foramen primum, a new opening, the foramen secundum, appear in the upper portion of the septum primum, just before the foramen primum closes. This provides uninterrupted shunting of blood from the right atrium directly to the left atrium. Another interatrial septum, the septum secundum, develops to the right of the septum primum and extends down like a curtain. This septum never forms a complete partition in the atrial cavity. It creates an opening known as the foramen ovale. Let's continue with ventricular septation. From the interventricular ridge, a muscular septum advances into the common ventricle towards the endocardial cushion. However, this muscular interventricular septum never reaches the endocardial cushion. Thus, the 2 ventricles are only partially divided. The formation of the aorticopulmonary septum takes place in the Truncus arteriosus and conus cordis, dividing them into 2 arteries, the aorta and the pulmonary artery. During the 5th week, pairs of conotruncal opposing ridges appear in the Truncus arteriosus and conus cordis. These ridges, or cushions, spiral toward each other and distally. The truncal and conal ridges fuse to form the aorticopulmonary septum, which separates the aorta and the pulmonary trunk. The aorticopulmonary septum extends further down towards the muscular part of the interventricular septum, along with the endocardial cushions, to form the membranous portion of the interventricular septum. When the membranous septum fuses with the muscular septum, the right and left ventricles become completely divided. In the fetal circulatory system, the umbilical vein transports blood rich in oxygen and nutrients from the placenta to the fetus. Most of the blood from the umbilical vein enters the ductus venosus, bypassing the liver to reach the inferior vena cava, or IVC. In the IVC, the oxygenated blood from the placenta is mixed with the deoxygenated blood from the lower parts of the body. Let's review this in more detail. As blood from the IVC enters the right atrium, a large portion of it is shunted through the foramen ovale directly into the left atrium. A small valve, which is the septum primum, located on the left side of the atrial septum, lies over the foramen ovale and helps prevent blood from moving in the reverse direction. Blood from the left atrium enters the left ventricle, then the ascending aorta. Deoxygenated blood returning from the head and upper limbs via the superior vena cava reaches the right atrium, passes through the tricuspid valve to the right ventricle, then out through the pulmonary artery. Most of the blood in the pulmonary artery bypasses the lungs by entering the ductus arteriosus, which connects the left pulmonary artery to the aortic arch. Only a small volume of blood enters the pulmonary circulation because the lungs are collapsed and their blood vessels have a high resistance to flow. As a result of this connection, the deoxygenated blood is prevented from entering the portion of the aorta that provides branches that supply the brain. Right after delivery, the supply of oxygen from the placenta is interrupted and respiration begins. The ductus arteriosus begins to close through the contraction of its muscular wall. The obliterated ductus arteriosus becomes the ligamentum arteriosum. The ductus venosus also constricts and becomes the ligamentum venosum. When a newborn's first inspiration fills the lungs, the pulmonary blood flow increases as the pulmonary vascular resistance and pulmonary artery pressure decrease. This, in turn, raises the pressure in the left atrium. When left atrial pressure exceeds the pressure in the right atrium, the septum primum is pressed over the septum secundum, closing the foramen ovale to become the fossa ovalis. The left circulation becomes a high-pressure circuit, thus eliminating the right-to-left shunt and creating a double circulation system, that is, the pulmonary circulation and the systemic circulation. On the right side of the heart, deoxygenated blood from the superior and inferior vena cavae enters the right atrium. Blood then flows through the tricuspid valve into the right ventricle. From the right ventricle, it is then pumped to the lungs through the pulmonary arteries. Within the lungs, the blood is oxygenated. This oxygenated blood returns to the heart through the pulmonary veins to reach the left atrium. From the left atrium, blood passes through the mitral valve to the left ventricle, where it is pumped out to the systemic circulation through the aorta. Ostium secundum atrial septal defect is a congenital heart abnormality characterized by a large opening in the atrial septum. It is typically located within the area bordered by the limbus of the fossa ovalis. It is caused by inadequate development of the septum secundum, or by excessive resorption of the septum primum. A defect in the atrial septum will create a left-to-right shunt due to a pressure gradient. Since left atrial pressure exceeds the pressure in the right atrium, blood will flow from the left atrium through the defect to enter the right atrium. Ostium primum defects are the result of an inability of the septum primum to fuse with the endocardial cushions. These defects are typically associated with AV malformations and, at times, ventricular septal defects. They are usually combined with a cleft of the anterior leaflet of the mitral valve. Again, a defect in the atrial septum will result in a left to right shunt. Muscular ventricular septal defects are caused by either a deficient fusion of the muscular septum walls or by excessive resorption of the muscular tissue during ventricular development. This results in an opening in the muscular portion of the ventricular septum, leading to a left to right shunt. Membranous ventricular septal defects are the most common cardiac congenital defects. As mentioned before, the aorticopulmonary septum extends further down towards the muscular part of the IV septum, along with the endocardial cushions, to form the membranous portion of the IV septum. Incomplete fusion of the aorticopulmonary septum with the muscular interventricular septum results in an opening in the membranous portion of the interventricular septum. Again, this defect will yield a left to right shunt. Patent ductus arteriosus, or PDA, is a congenital cardiac defect characterized by failure of the ductus arteriosus to close after birth. The ductus arteriosus normally closes within the first 2 days of life through the contraction of its muscular wall to become the ligamentum arteriosum, as seen on the left. In contrast, the illustration on the right shows a patent ductus arteriosus. The ductus arteriosus may remain patent in certain conditions, such as preterm delivery, congenital rubella syndrome, and chromosomal abnormalities. Due to the pressure gradient between the aorta and the pulmonary artery, the blood will flow from the aorta into the pulmonary artery. Persistent truncus arteriosus is a cyanotic congenital cardiac defect characterized by a single arterial trunk. This is caused by incomplete conotruncal septation of the truncus arteriosus. This results in an underdeveloped aorticopulmonary segment. Since the aorticopulmonary septum participates in the formation of the membranous portion of the interventricular septum, this defect is associated with a membranous VSD. With persistent truncus arteriosus, the common trunk typically overrides the VSD. Thus, it receives blood from both the left and the right ventricles. Transposition of the great vessels is a cyanotic cardiac defect in which the aorta and the pulmonary artery are switched. This defect is caused by a failure of the aorticopulmonary septum to grow in the normal spiral direction. Instead, it extends straight down. The straight aorticopulmonary septum that ensues causes the aorta to originate from the right ventricle and the pulmonary artery to originate from the left ventricle. Therefore, two closed circuits will be created, which is not compatible with life. In order for a newborn with transposition of the great vessels to survive, this defect must be accompanied with an ASD, VSD, or PDA, which would connect the two circuits, allowing for the circulation of oxygenated blood. Tetralogy of Fallot is the most common cyanotic congenital heart defect. Tetralogy of Fallot occurs when the aorticopulmonary septum fails to align properly and shifts anteriorly to the right. This leads to an unequal division of the conus, resulting in a wide overriding aorta and a small stenotic pulmonary artery. Displacement of the septum produces 4 cardiovascular alterations: pulmonary stenosis, membranous VSD, an overriding aorta, and hypertrophy of the right ventricular wall secondary to elevated pressure on the right side. Tetralogy of Fallot presents with a right-to-left shunt, with blood flowing from the right ventricle through the membranous VSD into the left ventricle. This results in cyanosis.